postnatal and the pelvic floor. So going back to consider the pelvic floor function in context to a woman's lifespan, postnatal recovery is a significant phase and everyone is different depending on the impact or injury to the pelvic floor and the adjacent tissues and structures during vaginal birth. This is a great visual that can help you appreciate all the structures involved close to the birthing canal. If you have a look, you can see 3 openings: the urethra at the top, the vagina, and then the anus at the bottom. Just to appreciate, during birth, the pelvic floor muscle, the levator ani, and the birth canal tissues have to stretch just more than 3 times their original length. Damage can occur to the pelvic floor muscles, the area between the vagina and anus, where a lot of muscles anchor to, and also the anus itself. In doing so, this impacts soft tissues where the muscles attach, can impact ligaments, nerves, and bones. The pelvic floor opening obviously needs to expand during childbirth, but after birth, normal closures need to maintain the support in the area. And some women suffer significant injuries, and closure of these are never effective again. Damage to the pelvic floor group of muscles called the levator ani is the single most important birth-related factor associated with pelvic floor disorders after birth or as the woman ages, particularly through menopause. An estimated 85% of women sustain an injury during childbirth. This diagram shows the crowning of a baby during birth, and the diagram on the right depicts the pelvic floor muscles involved that will need to stretch. Those injuries will cause symptoms such as urinary incontinence, with 15 to 30% of first-time mums ever experiencing it. At 3 to 6 months postnatally, up to 56% of first-time mums will have a pelvic organ prolapse of a grade 2 or more, which I'll talk to more later. And 1 in 5 mums complain of bowel incontinence at 1 year postnatally. Within vaginal births, there are risk factors that can impact pelvic floor injuries. These can depend on mum's age, weight, and family history. Pelvic floor disorders are primarily based on the first birth experience, with increased risk if there's been any significant tears to the perineum, if any instruments were involved, or if the second stage is longer than an hour. The baby can influence risk factors including its weight, large head, and the position during birth. Other contributing factors could include women with connective tissue disorder or having a poor pelvic muscle tone. Here is an image where you can see how a baby's head size, the blue balloon, can impact birth, with the ribbons depicting the pelvic floor muscle fibers. These are the only muscles in the body that ever need to stretch 3 times the original tissue length and then recover from that. Now imagine your hamstring doing that. This picture shows how the nerves that control the closing muscle for the anus may be impacted in birth, with the potential compression and stretch during delivery. So vaginal birth involves the stretch of the pelvic floor muscles up to 3.2 times its original length. This can result in changes in supporting ligaments, potential nerve damage, and muscle tears, often at the perineum between the vagina and anus, but this can be extended into the muscle tissue, and muscle avulsion or detachment of muscle from the front pelvic bone can occur. Caesarean section obviously involves major abdominal surgery, as Dr. White has explained, involving the layers of tissue of the abdominal wall and uterus. And because they are pulled apart, this can exacerbate the rectus abdominis muscle separation, or the diastasis. During healing of the scar, the connective tissue around the cut can form adhesions and affect how well the muscle can glide and contract through the surrounding tissue. In the first 6 weeks after birth, the pelvic floor is weak and has poor coordination. The pelvic organs are still in a lowered position in the pelvic bowl after carrying the weight of the baby, and the bladder neck and base is more mobile. All these things can contribute to bladder incontinence. For C-section delivery, the mother is advised for at least 6 weeks to avoid lifting anything heavier than her baby. Symptoms of pelvic floor disorders postnatally are similar to what we've covered in the pelvic floor presentation. In addition, they may experience some urgency in bladder or bowel, they may have difficulties with emptying, they could have constipation or pelvic floor pain where any wounds are, including the perineum. They may experience repeated urine infections, have pain with sex, and also experience lower back pain. So looking closer at birthing injuries, particularly those that affect the pelvic floor. In summary, we have pelvic floor damage, perineum damage, pelvic prolapses, nerve damage, and even fractures. More rare conditions, which are a medical emergency, include an inverted uterus where the placenta doesn't detach from the uterus wall, causing it to turn inside out, or a ruptured uterus where the placenta pulls away, causing severe bleeding. I've referred to these a lot. So a perineal injury is a tear to the soft tissue that occurs between the vagina and the anus due to the stretch put on the area when birthing. As Dr. White has mentioned, the alternative is an episiotomy or a surgical incision made to the perineum with the idea of creating more space to the birthing canal. There are different degrees to these tears depending on the tissue involved, the worst being a 3rd and 4th degree involving injury to the muscle that closes the anus. These severe injuries occur in 4 to 9% of vaginal births and can have devastating consequences to a woman's function, with 30 to 7% suffering from bowel incontinence. The integrity of the perineal region is really important, as there's a lot of major muscle attachments here, and any injury can lead to weakness in the pelvic floor, but also pain in the area affecting their sexual function. Looking down into the bowl of the pelvic floor, the pelvic floor muscles in green is the levator ani, which is the one that needs to stretch up to 300% when giving birth vaginally. Injuries to this muscle occurs in up to 19% of women. The muscle injury can include a tear or a avulsion where it pulls off the bone, either partially or entirely. The muscle will not recover from this, and it's not something that is surgically mended. Levator ani injuries are a leading cause of pelvic floor disorder and present in 55% of women with problems later in life. So we've already talked about pelvic organ prolapses before. So this is when one or more organs, such as the bladder, uterus, or rectum, descend into the vagina because the supporting structures either stretch or weaken, losing their anatomical function. The severity of a prolapse, or the degree at which it descends into the vagina, can be defined by its stage. Stage 3 and 4 is where the vagina is protruding externally and needs referral to a gynecologist. With breastfeeding, the estrogen levels are low, which can cause more tissue laxity, and so it's important to know that breastfeeding clients are at a higher risk of developing a prolapse. These are the different types of pelvic organ prolapses that we've already covered in another presentation. Prolapses may be present immediately or within the first year postnatally, but I also want to highlight that pelvic floor failures resulting in prolapse is not necessarily immediate and may happen later in a woman's lifespan. 6 weeks after birth, women have a medical checkup, but this does not involve any review of the pelvic floor or nearby structures, including any internal assessments. Dr. White has talked about the body's recovery of the cardiovascular system and general healing. For the recovery of the pelvic floor tissue, it's estimated to be 4 to 6 months long. For the healing of the C-section, the uterus and the abdominal wall, at 6 weeks, it's regained 50% of its tensile strength, but it takes much longer, from 6 to 7 months, to get closer to 100% of its healing. And this aligns with diastasis recovery, around 6 to 8 months. To review recovery of the pelvic floor, a postnatal warrant of fitness is recommended by a pelvic floor physiotherapist. This incorporates assessing the pelvic floor muscles of strength, endurance, and coordination, and setting up a program, assessing the abdominal wall for a diastasis, providing guidance for scar management, addressing any musculoskeletal problems, and integrating pain management as needed, and just overall providing guidance to returning to movement with daily activities and living, and returning to exercise and sport. ACC now recognise birthing injuries, and pelvic floor physios can raise claims as per any other injury. It's important that mothers are aware of this treatment avenue. As part of the postnatal WOF, specifically for fitness clearance, pelvic floor physiotherapists are looking at pelvic floor recovery with some measurements around the perineum. We're looking at the integrity of the levator ani muscle and the closing muscles for the bladder and the bowel, and also evaluating the extent of any prolapse present or the risk of a prolapse. As mentioned before, we'll also be addressing any musculoskeletal or pain problems. To treat any pelvic floor dysfunctions, pelvic health physios will be assessing and setting up pelvic floor muscle training programs or doing muscle sphincter rehab. This may involve using pessary devices which help offload the pelvic floor. We also would be providing advice for bladder and bowel emptying, lifestyle education and modifications, and referring on as needed. So, although incontinence might be common, it is not normal. So, if your clients hint at any problems in the pelvic region, encourage them to see medical or a pelvic health physiotherapist.